Okay, today we shall discuss a disease of a kidney known as nephrotic syndrome. Nephrotic syndrome is a disease of a kidney. First, we shall discuss the theoretical aspect of the nephrotic syndrome and try to interlink with the clinical insight of a disease. So in this way, by linking the theoretical aspect of the topic with the practical insight, we will try to build a core concept of this topic. So let us begin with nephrotic syndrome is basically a glomerular disease. Nephrotic syndrome, which is a glomerular disease, is characterized by proteinuria. So the basic pathophysiology of this disease is proteinuria. Let us see how this proteinuria occurs in nephrotic syndrome. Let us draw a structure of a nephron and understand how this proteinuria will lead to various clinical signs and symptoms. So this is a structure of nephron, and the red vessel indicate the afferent arteriole and the efferent arterioles. So normally there is no filtration of protein through this glomerular basement membrane. Why there is no filtration of protein through this glomerular basement membrane is that in the basement membrane of the glomerulus there is a negatively charged glycosaminoglycan which is known as heparan sulfate. This glycosaminoglycan, which is known as heparan sulfate, is present in the basement membrane of the glomerulus. So this filtration membrane is basically a negatively charged due to presence of heparan sulfate. And all the circulating proteins, majority of the circulating proteins are also negatively charged, like albumin, globulin, all these proteins are negatively charged proteins. So while crossing these glomerulus capillaries, these proteins are not filtered through the basement membrane because like charges repel each other, and the protein which is negatively charged is repelled by the heparan sulfate which is also negatively charged. So this glycosaminoglycan protect the filtration of the protein through this glomerular membrane. So in nephrotic syndrome there is somehow destruction of this heparan sulfate. Interleukin 2 is responsible for destruction of this heparan sulfate. Now from where does this interleukin 2 comes? Interleukin 2 is basically produced by T cell dysfunction. So somehow there is inherent defect of the T cell which lead to production of excess of interleukin 2, and this interleukin 2 in turn destroy the negatively charged heparan sulfate coating of the basement membrane, which results in filtration of the circulating protein. So there is no negatively charged to repel the negatively charged protein. So ultimate result is the filtration of the protein through this basement membrane of the glomerulus, and which result in proteinuria, protein in urine. Now how much protein is produced in the urine, or how much protein is filtered through the membrane? We can quantify this protein in the urine by quantification of protein in the urine, but we will discuss this in our further lectures. Now you have to understand that there is more than 1 gram per meter square per day protein filtered in the urine in nephrotic syndrome, and this more than 1 gram is known as heavy proteinuria. So to sum up, in nephrotic syndrome, there is loss of negatively charged heparan sulfate in the glomerular basement membrane, which in turn does not oppose the filtration of the albumin, globulin and other negatively charged protein in the circulation, which leads to excess protein in urine known as proteinuria, and this proteinuria is usually heavy or massive proteinuria that is more than 1 gram per meter square per day. So the basic pathogenesis of this disease is proteinuria, that is massive or heavy proteinuria. So there is loss of circulating protein in the urine, and as there is loss of circulating protein in the urine, all the major circulatory proteins are the albumin. So proteinuria will result in hypoalbuminemia. Proteinuria will in turn result in hypoalbuminemia because of loss of protein in the urine. And this hypoalbuminemia, the albumin which is responsible for maintaining the osmotic balance of the fluid is lost. So now there in circulation there is less amount of albumin, which will the function of which was to hold water. Now as a result there is no albumin in the circulation to hold water in the circulation. The circulating water will now shift to the other compartment. From the extravascular compartment it can shift to the intravascular compartment, or it can shift to the interstitium, leading to edema. So hypoalbuminemia will lead to edema. And as there is shifting of fluid from one compartment to other compartment, that is circulating compartment to the interstitial compartment, there is less amount of circulating fluid in the circulation, that is in the vascular compartment, and this will result in hypovolemia. Hypovolemia will result in reduced blood flow to the kidney. All other organs will also be affected, but kidney is one of them which will be affected by low blood volume, which will result in production of renin, angiotensin, aldosterone system. Whenever there is reduced blood supply to the kidney in turn act by activating its system known as renin, angiotensin, aldosterone system to counteract hypovolemia. So as a counteract mechanism, now kidney will activate its aldosterone system, as well as there is release of antidiuretic hormone. Both this mechanism, renin, angiotensin, aldosterone system as well as antidiuretic hormone, will lead to sodium and water reabsorption. So this sodium and water reabsorption will further contribute to edema, excess amount of edema. Now you can see that there was massive proteinuria, which resulted in hypoalbuminemia. Hypoalbuminemia caused edema. This hypoalbuminemia will also cause synthesis of excess amount of beta lipoprotein. As there is loss of protein in the urine, now the liver will try to compensate or try to produce more amount of protein due to loss in the urine. But there is not enough substrate to produce protein. There is not enough substrate to produce protein like albumin, globulin due to excess amount of protein loss. So instead producing protein, now the liver will compensate by producing lipid that is beta lipoprotein, and this will cause hypercholesterolemia. So you can see that proteinuria, which caused hypoalbuminemia, and hypoalbuminemia caused edema, which in turn activated renin, angiotensin, aldosterone system due to less amount of circulating fluid, and which in turn caused sodium and water reabsorption and aggravated edema. And in compensation, of protein, the liver started producing lipid which causes hypercholesterolemia. In compensation, liver also started producing coagulation factor. So production of lipid as well as coagulation factor is as a compensatory mechanism. Compensatory mechanism due to protein loss. Now, this edema has resulted in sodium and water reabsorption from the kidney, which in turn aggravated edema. Now, there is not only albumin lost in the urine, but other proteins are also lost in the urine. Other proteins which are lost in the urine are transferrin, antithrombin 3. This transferrin loss in the protein will cause anemia. Antithrombin loss in the protein will lead to hypercoagulable state. As well as there is loss of immunoglobulin, basically IgG, which will lead to infection. So you can see the pathophysiology of the disease. If you have understand the pathophysiology of the disease, it is very easy to identify the clinical feature of the disease. You can see due to massive proteinuria, there was hypoalbuminemia, and hypoalbuminemia caused edema. So edema is one of the clinical features of the nephrotic syndrome. As there was excess amount of lipoprotein production as a compensatory mechanism, there was hypercholesterolemia. If you see the blood cholesterol level, it will be increased. And as well as there was increased production of the coagulation factor. Now this excess production of the coagulation factor and loss of antithrombin 2 in the urine will lead to thrombotic complication. As excess amount of coagulation factor will lead to activation of the coagulation pathway resulting in thrombosis, and antithrombin 2 which help to maintain the balance. So both the part is falling apart. Coagulation factors are increasing as well as anticoagulatory factor are decreasing. So it will lead to thrombotic complication. Loss of immunoglobulin will lead to infection. There is no protective mechanism left over if immunoglobulin is lost. There is no humoral immunity. Humoral immunity will not be enough to protect the person from the infection, so it will lead to infection. What are the infections that are usually encountered are the respiratory tract infection, the urinary tract infection. So this was the basic pathogenesis of the disease, in which we have also understood how a pathogenesis can help us guide the clinical feature of the disease. Now let us classify nephrotic syndrome. Nephrotic syndrome. There are various ways to classify nephrotic syndrome according to different parameters. So the first parameter is age of onset. If nephrotic syndrome occurs at birth to 3 months, we call this type of nephrotic syndrome as congenital nephrotic syndrome. If nephrotic syndrome occur in between 3 months to 1 year, we call them as infantile infantile nephrotic syndrome. And if it occurs between 2 to 8 years, we call them as childhood nephrotic syndrome. There is also a variant known as adult, which occur in adult or in pubertal life. It's known as adult or pubertal nephrotic syndrome. So these are the various classification of nephrotic syndrome based on age. Congenital nephrotic syndrome, the infantile nephrotic syndrome, childhood nephrotic syndrome, and the adult variant of the nephrotic syndrome. So let me talk something about this congenital nephrotic syndrome. This congenital nephrotic syndrome, basically there is an associated family history, and it is also associated with large size placenta during pregnancy, as well as torch infection in mother, large size placenta in mother. And it is basically a type of inherited disease. Not much to know about this disease. The other classification of the nephrotic syndrome is based on the etiology. The etiological classification of nephrotic syndrome. It can be primary nephrotic syndrome, there is no known cause, which means when we call the nephrotic syndrome as primary nephrotic syndrome, it means that there is no established cause of nephrotic syndrome, and hence it is called as idiopathic nephrotic syndrome, which is almost most common. Almost 90% of nephrotic syndrome, we are not able to establish the cause for that nephrotic syndrome. So it is a primary nephrotic syndrome or idiopathic nephrotic syndrome. In secondary nephrotic syndrome, there is a established cause. In secondary, there is a established cause. It can either be a multi-systemic disease. Multi-systemic disease can also cause nephrotic syndrome. And when there is established cause of nephrotic syndrome is occurring either due to this or due to that disease, we call those as a secondary nephrotic syndrome. When we are not able to identify any cause of the nephrotic syndrome, we call it as a primary nephrotic syndrome. And the most common type of nephrotic syndrome is 90% primary nephrotic syndrome. In secondary nephrotic syndrome, due to some other disease, there is also an association with nephrotic syndrome. In such condition, we call this as a secondary nephrotic syndrome. It occurs in multisystemic disease like systemic lupus erythematosus. It can occur in collagen vascular disease. It can also occur in polyarteritis nodosa. It can occur in amyloidosis. It also occurs due to some drugs intake like lithium, gold, penicillamine, NSAIDs can also cause nephrotic syndrome. So these are the secondary causes of nephrotic syndrome. Post-infection, sometimes nephrotic syndrome occurs post-infection. And it is very difficult to distinguish it from nephritic syndrome, glomerulonephritis clinically, when the nephrotic syndrome occurs post-infection. It occurs after hepatitis B, hepatitis C infection. It can occur after hepatitis B, hepatitis C infection. It can also occur after malaria and toxoplasma infection. So there is another important classification of nephrotic syndrome based on histopathology. Based on histopathology, nephrotic syndrome can be characterized into two different categories. The first one, in which there is no much significant change in histopathology of the glomerular membrane or the glomerulus unit, and in the second one, there is much changes in the histopathology of this glomerulus. So, in which there is no changes or there is minimum changes, we call this as minimum change nephrotic syndrome, in which there is minimum change in the histopathology of the glomerulus. What kind of change? In light microscopy, there is no change. Changes are only seen in electron microscopy. That are also non-specific change. That is loss of food processes of podocyte. And in electron microscopy, there is no complement or immune complex deposition. Just the glomerular basement membrane, which contains podocyte and a food processes which is helping them attach to the membrane or the epithelium, these food processes are lost in minimal change disease, and there is no complement deposition in the basement membrane of the glomerulus, and there is also no immune complex deposition in minimal change disease. That means there is significantly no changes seen in histopathology of minimum change nephrotic syndrome. When we do biopsy of the kidney and examine for histopathological changes in minimal change disease, we will find only loss of food processes of the epithelial podocyte, as well as there is no complement or immune system deposition in the basement membrane of the disease. On the other hand, in nephrotic syndrome with significant lesion, in nephrotic syndrome with significant lesion, we will see a characteristic immune complex deposition, complement deposition, as well as we can see sclerosis, and sometimes we see proliferation of mesangium. So various names are given. If there is more sclerotic change, we say that significant lesion is a type of glomerulosclerosis. If there is proliferation of the mesangium, we used to say there is mesangial-proliferative glomerulonephritis. So accordingly, various names are given for the significant lesion. So now let us discuss about the clinical features. Clinical features of nephrotic syndrome. So this is the most important part regarding your practical or clinical aspect, as well as integrating it with the pathophysiology of the disease. As we have learned only the pathophysiology of the disease, we have already learned. Now it is very easy for us to study the clinical feature of the disease. I told you, due to proteinuria, there is hypoalbuminemia, and hypoalbuminemia will lead to edema. So the first clinical feature is edema. Now we have to study edema in this great detail. How the edema occurs, in which part the edema will occur first, and how is the progression of the edema. Edema usually starts with in the periorbital region. So there is periorbital puffiness of the face, which is early morning when the child or when her mother makes him get up, and when he combs her or his hair, he can see the puffiness of the face. So at first there is periorbital edema or facial puffiness, which is followed by pedal edema, edema in the legs, which is always bilateral. Bilateral pedal edema, which is pitting edema, bilateral pitting pedal edema. Now, after facial puffiness and bilateral pitting edema, the edema generally involves the whole body, which is known as generalized edema. It may result into ascites. It can result in hydrothorax, and it can also result in scrotal swelling. It can result in ascites, hydrothorax, as well as scrotal swellings. So, and when two or more compartment is involved, we used to term this edema as a generalized edema. Second one, due to edema, due to hypoproteinemia and protein loss in the urine, there is also loss of immunoglobulin, which will result in infection. And what type of infection are usually dominant in nephrotic syndrome? It can be respiratory tract infection, it can be urinary tract infection, it can be spontaneous bacterial peritonitis. Now I will discuss little bit about spontaneous bacterial peritonitis and why does it occur. In abdominal organ, the viscera is covered by visceral peritoneum. And there is another covering above the visceral peritoneum, which is known as the parietal peritoneum, and there is a space between this visceral peritoneum and parietal peritoneum known as peritoneal cavity. So this peritoneal cavity normally contains very less amount of fluid. There is no much fluid in this peritoneal cavity, and this fluid acts as a lubricant for rubbing the visceral peritoneum against the parietal peritoneum. Very less amount of fluid is present in the peritoneal cavity. In ascites, there is increased fluid in the peritoneal cavity, and under the visceral peritoneums, there are viscera, different viscera, the intestines, the liver, all viscera are within the visceral peritoneum. So, we will mainly focus on the intestine. Inside the intestine, there is normal bacterial flora. The normal bacterial flora is present within the intestine. So, due to excess fluid collecting in the peritoneal cavity, now this bacterial flora which is present inside the gut will start migrating towards the fluid, as the fluid will be a rich source for our growth, for the bacterial growth. So this bacteria will start migrating through the wall. It will not perforate the wall of the intestine, but it will migrate through the wall. And this type of migration, we call it as transmural migration of the bacteria. So the bacteria will migrate transmurally and reach to this ascitic fluid of peritoneal cavity and start multiplying in this peritoneal cavity fluid, the ascitic fluid, and result in peritonitis. This type of peritonitis, we call it as spontaneous bacterial peritonitis, and it can only occur in condition of ascites. So there are many conditions which can lead to ascites, but spontaneous bacterial peritonitis most commonly occur in liver cirrhosis patient with ascites. It can also occur in ascites in nephrotic syndrome. So these are the infections common in nephrotic syndrome. Now the patient can also present with us with oliguria. Oliguria is decreased frequency of urination. As a result, there was edema and hypovolemia. Hypovolemia will result in less blood flow to the kidney and less GFR and less urine production due to shifting of fluid from one compartment to another compartment. there is ultimately less blood supply to the kidney, that is less renal blood flow, and the less renal blood flow will reduce the GFR, there is less GFR and less urine production, which will result into oliguria. It can also sometimes result in anuria. So this is the basic pathophysiology of how oliguria is produced. Some patients with nephrotic syndrome present with us with hypertension and hematuria. If hypertension and hematuria is present in a patient with nephrotic syndrome, we have to always suspect a nephrotic syndrome has to be with a significant lesion. In minimal change nephrotic syndrome, there cannot be hypertension and hematuria. There is very less chance, almost nil chance of patient presenting with hypertension and hematuria in minimal change nephrotic syndrome. So these are the clinical features of nephrotic syndrome. Now let us compare the minimal change nephrotic syndrome in which the histopathology there is no significant change with nephrotic syndrome with significant lesion. In minimal change nephrotic syndrome, usually the age of onset is 2 to 8 years. The child with 2 to 8 years will be affected most with minimal change nephrotic syndrome, where there is less histopathological changes. Why? No one knows. And usually male are affected more than female. In nephrotic syndrome with significant lesion, it is usually the older children which are affected more, and male and female are equally affected. Steroid has a very good response in treating minimal change nephrotic syndrome, but it is not as good for treating nephrotic syndrome with a significant lesion. As I told you, in minimal change nephrotic syndrome, there is very less histopathological changes. So the serum complement level will be normal. There is no complement deposition in the basement membrane. So in the serum, if you check the level of the complement, it will be normal. Whereas in nephrotic syndrome with significant lesion, all the serum complement level are deposited so that when you check the serum complement level, it will be decreased. C3 will be decreased. About the protein selectivity, minimal change nephrotic syndrome, there is highly selectable proteinuria. Highly selective proteinuria. In which there is only albumin loss. Whereas in nephrotic syndrome with significant lesion, there is variable amount of protein loss. All the proteins are lost in albumin plus globulin and other immunoglobulin means different types of protein are lost in nephrotic syndrome with significant lesion, whereas in minimal change nephrotic syndrome there is highly selective proteinuria, which means only albumin is lost in urine. So these are the major differences between nephrotic syndrome with significant lesion as well as